Thanks to Chairperson for kind words. And again, I am thankful to Dr. Rutul and organizing committee for inviting me at PhD Con. See, now my job is a little bit difficult because Dr. Arvinda says straight away metformin is no. Ma'am is giving a lot of the evidences and ma'am is firing just like anything. So I have to prove myself how we can use the metformin sometimes in pregnancy. See, we all know metformin is a tool of the precision medicine in pregnancy, and we must have to identify the specific, well-defined clinical scenario where the risk as well as the benefit profile justifies its use. I think if you all of you can understand the sentence, then I think my job is over, right? So with this background, I am going to just start my presentation. We all know the metformin is not just like the glucose lowering agent. There are a lot of the other mechanisms of action just like it's going to create a AMPK activation, and this improves the peripheral insulin sensitivity. Not only that, it will also reduce the hepatic glucose production, and there are a lot of the pulmonary benefit going to be there. It has been a very anti-inflammatory as well as vascular benefit. And in pregnancy, it may modulate the placenta function as well as the maternal hypergonadism. Now coming to the point, in which condition we can use sometimes. Just the friends forget all the things what Dr. Arvinda told, what basically Madam told. Just listen me and see you can come to know, because you are going to get such of opportunity day in, day out in practice. There will be some of the question in mind when we can use metformin sometimes. Now look at the slides, GDM. When the patient factors drive sometimes. See, when there is a cost issue, the patient is not want to patient is reluctant. They are not going to accept the reality they require insulin. Cold chain issue, already Madam told. Then the transportation is issue, then the patient is coming from a remote area, patient is not willing, sometimes social stigma. These are all concerns when you can put this pragmatic terms sometimes. Now second thing, the insulin phobia and poor compliance, because patient is going to require sometimes multiple insulin regime. We all know patient may be required the multiples of prandial or basal bolus. So because of that, patient is not going to willing for the insulin. You can use metformin sometimes. And when there is a risk of the maternal weight gain, you can use this metformin. Now, look at this trial. We all know the MIC trial, metformin GDM study, and what they observe it. Either the patient is going to receive the metformin and insulin, there will be any outcome as far as the fetal is concerned, but you can see here, there is a systemic review meta-analysis going to say us, the metformin is a little bit going to better than the insulin, reducing both the thing, maternal weight gain during pregnancy, as well as the pregnancy-induced hypertension. There is no any change of hypoglycemia. There is no other side effect. Now, MITI trial, we all know, this trial was done in a type 2 diabetes in pregnancy. You can see here, there will be no any significant difference between the group as far as the neonatal morbidity and mortality is concerned. But here, you can see here, the metformin-treated women of infants, they having a better glycemic control, number one. They are having a lesser insulin doses, number two. They are having lesser weight gain. There are a lot of benefit, and there is a fewer C-section also. But there will be some little bit risk of the small gestational age, what basically the SIR has told. Now, still, long-term risk is debatable, but ultimate questions for the sometime approach, does fetal program lead to harm? Look at this trial, MIG tofu. Here, what they want to show here, the aim of the purpose of the study here, of tofu study at 2 years of the age, was not compared to just body composition children, but you can see here, when the children is going to expose to the metformin having a larger sort of the subcutaneous fat, but overall body fat is not going to hamper, number one. Second thing, they want to also show if the patient is going to receive metformin sometimes will develop less visceral fat or what is going to impact on the overall metabolism. Here, madam already described this basic study. The age of the 7 to 9 years, there will be some little risk of this small percentage, but after 9 years, we have to be careful because this metformin is going to create the risk of the obesity. So primary concern, ultimately metformin may be create a risk of child obesity, and second one, it will also going to increase the risk of the subcutaneous fat, but not total fat. So we have to keep in mind a lot of things. Is there any Indian data? Yes, madam already told here, the Datta and all the scientists, they have done the study on what they want to know here. The data was published in the end of 2024. What is going to long-term impact on offspring between 5 to 11 years of the age? And you can see here, the primary outcome, just they want to see what is going to happen body mass index. And secondary outcome, what is going to alternate in the orthopedic measures, obesity, and change level of the lipids. Right? You can see here, the metformin used in pregnancy, they have shown there is no any adverse outcome as far as either patient is going to receive the insulin or the metformin. So coming to my point, here the final risk-benefit calculation is when you are going to see the maternal focus, we have to consider metformin because there is a lot of the advantage. It is going to reduce the risk of the maternal weight gain. Not only that, it's also going to reduce the risk of the hypoglycemia because insulin, we all know the risk of the hypoglycemia will be there when the cost is issue, convenience is issue, acceptance is issue, adherence is issue. Definitely, as far as you are going to see maternal side, we have to, Dr. Ravinda, keep in mind, we have to use the metformin. We cannot ignore it, okay? Once the mother is there, then the child will come, okay? So as far as the fetus point of view, I am definitely agree with Dr. Arvinda here because it will go into risk of the small gestational age, the long term, and there will be a little bit risk of the metabolic obesity. So here just I would like to present one case. I think some type of case in day and day out we are going to see our practice. 32-year-old lady, gravida 2, diagnosed GDM at 28 weeks ago. She is having a BMI 34, moderately obese. History of the significant weight gain in the past pregnancy. Look at the fasting sugar here. Fasting is 118, post-meal sugar is 168 after the 2 weeks of MNT. And patient having a lot of anxiety and she straight away told me, sir, I don't want to take the insulin. Now what could be remedy? I have no choice. Just like the basically beggar, I have no choice. I have no choice because I want to continue her pregnancy. So here I have given detailed counseling and I have started metformin 500 mg BID and gradually escalated up to 1000 mg BID and continue MNT. And look at the outcome. The glycemic control is very good. A1C was fantastic. There will be very minimal 2 kg weight gain. We have also done fetal monitoring and you can see here the fetal monitoring we have done it. There was no any SGA, there was no any LGA also. And she has delivered very cute baby boy at the 39 weeks. So this is the baby weight outcome you can see 3.1 kg. So now coming to the second PCOS. This is a very common thing. Before the 2020, there was a historical rationale with the metformin used prior to conception to induce ovulation. As far as the miscarriage is concerned, there will be also the myth is there, they were reducing the risk of the miscarriage. And third one, if you are going to use the metformin, there will be a later risk of the GDM in PCOS. Now, is there any trial? Yes, look at this slide, you can come to know. The Venki and all the other scientists, they want to know, okay, main objective of trial was there just to see if you are going to use the metformin from first trimester to the delivery, it will going to reduce the pregnancy complication in women with PCOS? Yes or no? You can see what are the basically the results. The main they want to see there, what could be any impact on prevalence of the preeclampsia, GDM, as well as preterm delivery. You can see conclusion, metformin treatment, if you are going to use from the first trimester to delivery, there is no reduce the pregnancy complication in the PCOS. So again, this another trial, PREGMET trial. You can see what is the outcome in pregnancy women with PCOS. If you are going to use metformin, there will be a little bit benefit in terms of the reduction of the miscarriage as well as preterm birth. But there is no any positive impact as far as the GDM is concerned. So what the ADA, they have given statement in 2025, metformin should be discontinued by the end of the first trimester. But my recommendation is here, it is safest, sometime approach based on the modern data, whatever analysis could be, because we can give benefit to reduce of the miscarriage. So you can continue, you can use it, but just be safer. You stop at the time of the conception as well as or when patient is going to be a positive pregnancy test. Again, second study, I will also going to say here, you can use metformin sometime in such type of cases. 26-year female, diagnosed PCOS, she is taking metformin 1.5 gram for the regular cycle. She is going to become positive pregnancy test here, and the patient with dilemma because she came to the Google. Okay, if the metformin is benefit, it is going to prevent miscarriage. So what I have to do? What sir you advise? I have the detailing counseling. You can continue metformin, but we have to cautious because there will be a risk of the small gestational age in the future. So here, what I have done it, I have continued over the 7 days, and after the end of the 8 weeks, I have stopped it. Now, what are the rational evidence? You can see that there will be a minimal evidence as far as the benefits concerned. It will going to reduce the miscarriage, but we have to keep our eye opening because there will be a lot of the metabolic milieu occur in the fetus at later end. So here outcome is pregnancy is uncomplicated. There is no GDM, and some time for PCOS is only the preconception, not the maintenance stopping, which is going to help us. Now, last 2-3 slides, pre-GDM. We are going to see a lot many setup of T2DM patient in our practice when they require very high doses, supraphysical insulin doses when more than 2 units per kg body weight. Now, what is here we can do? How we can reduce the insulin dose burden? So we all know the higher insulin doses is going to contribute excessive maternal weight gain and creating cycle of increased resistance. So here we have used the metformin is not as a just replacement, but as an insulin as an agent. So a lot of monitoring and counseling to be required. As far as the glycemic control is concerned, fasting sugar should be less than 95, 1 hour sugar less than 140. Fetal growth has to be monitored frequently, and whenever you are going to find out if there is a fetal growth is decreasing or we have to stop metformin, and at that time we have to start the metformin. So these are the last slides. I would like to summarize my talk here. There are 3 C's for the sometimes case-based case, we have to take a call, either you can use metformin, like in GDM, T2DM, also PCOS. When patient having a cost issue, acceptance, availability, adherence could be issue, you can use. Counseling is very important. We are choosing this oral option for your health and adherence, but we have to must baby closely, and definitely the caution to be required as far as the fetal growth is concerned, we require the proper sonography. Now, there is an official Indian contents we have received from CDS of 2025. If the clinically needed, the use of the metformin can be considered sometimes during the pregnancy and in periconceptual phase as an additional or alternative to insulin based on treating physician discussion. And this is from final word from my side. The maturity of evidence on metformin, which we no longer ask if we can use it, but when and for whom sometime is the highest form of the clinical judgment. I think I have cleared all doubts here, and I would like to know from audience, now tell us, either you want to use the metformin, you are favoring the Arvinda sir, or you are going to favor ma'am, or you are going to favor of me. Please raise your hand. Yes, for yes, yes. Yes, there are few hands. No. And sometimes, surrendering, yes. Just I want to end my talk here, and now session is over for the, thank you very much, thank you.